obesity. So, you see, ghrelin is a stimulator, appetite stimulator. It is a hormone. It is mainly found in the fundus of the stomach. The principle of bariatric surgery is either you reduce the size of the stomach or you create some type of malabsorption syndrome. Either you reduce the size of the stomach or you produce some type of malnutrition syndrome that will cause weight loss of the obese patient. Then selection criteria for the surgery. Recommend BMI 40 or more than 40 for the Western countries, or BMI 35 or more than 35 associated with 2 comorbidities. In Asian countries, it is less. Minimum obesity for 5 years. All the conservative treatments has failed. Patients should not have alcohol drink. If the patient is having psychiatric problem, he must be treated before the operation. Pregnancy to be avoided for the 2 years, within the 2 years. And the approximate age range is 80 to 55 years. Who do the bariatric surgery? It is a team work. Even the operation theatre where the bariatric surgery is done has a total separate equipment. Even the OT table, which is generally used for the operation, is not fit for obese patient. For obese patient, a special OT table is required, which is fit with the so many belts from top to bottom. We have to tie the patient with the belt with the special table, and it is very difficult to give anesthesia. Even you cannot put a IV channel. In some situation, anesthetist has to take the help of the ultrasonogram, portable ultrasonogram. They detect the location of the vein by the help of the ultrasonogram, then put the IV channel. It is so difficult to give IV drip to the obese patient. So, bariatric surgery is a team work. No single person can do this operation. Surgeons who is having bariatric training, physician with special interest in obesity, the competent interested physician is required for the team. Dietitian, all the trained nurses and OT staff, especially trained anesthetist, and the most important person is the psychiatrist. Pre-operative preparation is required before the bariatric surgery. Mental setup of the patient is important. You have to prepare the patient mentally that we are going to reduce the size of your stomach, and whatever amount you are taking now, it will be reduced to 10%. So you should be mentally prepared for this. We will not get that much of food after the operation. The patient must be mentally and psychologically prepared for the post-operative follow-up. Otherwise, the patient will fight with the doctor and sister. He will fight in the ward for eating. And this is the routine test. Urea, cholesterol, lactate, lipid profile, fasting, vitamin A, all these things. Now, what are the surgical options available? I told the principles of the surgery. Either you are reducing the size of the stomach or you are creating a malabsorption syndrome. Size of the stomach is reduced by two methods. One is the gastric banding and the second is the sleeve gastrectomy. I will show in the next slide. And other are gastric bypass, combined procedure, malabsorption procedure, etc. This is very popular operation. It is called gastric banding and the full form is laparoscopic adjustable gastric banding. Initially, you see this is the band. This band is a silicone balloon. Ethicon company has made this balloon. This is the upper part of the stomach. A pouch is created here up to the size of 30 ml only. The size of this pouch is 30 ml only. And all used part of the stomach does not come in contact with the food material. This pouch is adjusted by the help of the balloon. This is a silicone balloon. This silicone balloon is wrapped all around the upper end of the stomach. And this balloon is connected through a tube to a reservoir. Through this access port reservoir, 15 to 20 ml of normal saline is pushed through the tube and the balloon gets inflated. And after the operation, according to the result, we can adjust the pressure of the balloon through this access port without any operation, just putting a needle in the skin and putting the saline through access port. The amount can be adjusted. That's why it is called adjustable band. It is done by laparoscopic surgery. The access port is kept in the abdominal, on the abdominal wall, above the rectus muscle, below the skin. It is easily accessible and palpable. It is a restrictive procedure, decreasing the stomach volume to 15 to 30 ml, narrowing its outlet into distal stomach. It was first performed by the Carrier in 1992. About 50% all surgical procedures in many countries is a very simple procedure. The chance of complications are very minimum. It is a maximum 1 hour procedure and maximum stay is 2 to 3 days in the hospital. The rate of complications are very minimum. That's why this operation is very much in practice all through the world. to 5% effective body weight loss. Effective body weight loss means loss of body weight which is more than the normal weight. Suppose a patient is having, patient expected body weight is 80 kg and he is having 120 kg weight. It means he is having 40 kg extra weight. That 50% of that extra weight will be lost within 2 years, and that is called effective body weight loss. And as I told that it is a very simple procedure, chance of complications are very minimal, risk of operation is less, but risk of anesthesia is there because patient may have some complication due to anesthesia. Then comes the sleeve gastrectomy. This part of the stomach is kept and this part is resected out. So I can say 80% of the stomach resected out, only 20% is kept for the function. So the size of the stomach is reduced. And as we are reducing the greater part that is the frontage of the stomach, so buildings will be out of the picture. This operation is also done by laparoscope, and thanks to the staplers company, they have made so many staplers. By the help of the staplers, this anastomosis is done, which causes less chance of leak during the post-operative complication. After the operation, this part of the stomach is reduced, is extracted out from the abdominal cavity. Only this part remains there. So this is a restrictive procedure, sleeve gastrectomy. Nowadays, this operation is more effective than the adjustable bed. It is relatively new operation, less post-operative monitoring. It is slightly riskier than the bending, mortality chance is bit high. Remove most of the Ghrelin secretory areas, 65% excess weight loss at 2 years. The other options, we have size of the stomach is reduced, a pouch is created here, and a Roux-en-Y bypass is done. The result of this operation is very good. The weight, effective loss rate is 60 to 70% in 2 years. But there is chance of complication, chance of stenosis of the stomach, chance of the stenosis of the stomach, chance of bleeding from the stomach, chance of the bleeding from the stenosis, chance of leakage from the stenosis. They may cause lethal complications and patient may die also. So effect is very 60 to 70%, but chance of complications are more. That's why I will tell later on. And biliopancreatic diversion. Effective loss is more than 75%, but chance of leakage are very high, and other malnutrition syndrome will develop. Protein deficiency, even the patient will have protein deficiency syndrome, vitamin deficiency syndrome, and lots of problems. So this is a good operation, but lots of complications are there. And then what will be the effect of surgery on the comorbidity? If the patient is having diabetes, then 76.8% completely resolved. Even the patient may not require any drug, diabetic drug after the surgery. 86% resolved or improved. Hyperlipidemia, 70% improved. Hypertension, 61.7% resolved. 85.7% resolved or improved. Obstructive sleep apnea, resolved or improved. These are general complications of the operation, complication due to anesthesia and for like any operation, incisional hernia, gallstone congestion, pulmonary embolism, etc. Late complication, the most important and dangerous complication is the anastomotic leak. And in case of bend, bend may slip, bend may erode, and pouch may become small or big like that. Protein energy malnutrition, vitamin and micronutrition, weight may be gained again. Patient will become obese again. So, what are the commonly done procedure? Laparoscopy, adjustable gastric bending LAGB is the most popular operation. Nowadays, slim gastrectomy becoming more popular. Roux-en-Y gastric bypass is a very good result, but the chance of complication, it is usually done at a highly specialized center. The result is very good. So the answer to the question, how to lose weight? It is bariatric surgery, which is now internationally called metabolic surgery because it is done for the metabolic diseases. Bariatric surgery is not a cosmetic surgery. It is a definitive treatment for the obesity. Laparoscopic procedure has minimized the complication of open bariatric surgery. And this picture has been taken from the internet. Now you can see lost 181 pounds after the laparoscopic gastric bypass. Before and after. Thank you.
Thank you very much, Dr. Bob. Being a pediatrician myself, I'm sure something new to me. But before anybody asks anybody,